This is a topic that hits very, very close to home. Was last year where I was involved in a very terrible accident. I got hit by a motor vehicle, lost consciousness for about 20 to 30 minutes, but in the end, I survived. Grab your piece of paper. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be pretty much looking at head injury. If you haven't yet subscribed to the channel, please subscribe to the channel. Hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. I've changed the format of how I'm going to be doing these videos from now on. So we will be having two segments in the video. One is a question for thought, and the other is of course a warm-up question. I will give the answer to the warm-up question at the end of the lecture, so make sure you watch the video till the end. And then of course your question of thought is pretty much going to be me triggering your thinking so that you can actually comment in the section below. So here's our question for thought today. What's actually the difference between head injury and injury to the head? Are they the same things? Do they differ? Please comment in the section below. I will pin the comment that I think is most relevant after I receive so many comments from you guys. So here's our warm-up question, and this is a short answer essay. So keep this in mind because we're going to give you the answers at the end of this lecture. So a 35-year-old patient is seen in the casualty following a road traffic accident. The patient smells of alcohol and has a laceration on the occipital area. Answer the questions below. What two things would you ask in the history? Explain how you would examine the occipital laceration. How would you assess the level of consciousness of this patient? List 4 localizing signs you would look for. List 4 reasons you might ask for a CT scan in this patient. So keep these questions in mind. I will give you the answer at the end of the video, so please make sure that you watch this video till the end, and let's get into the topic right now. So remember that head injury is just pretty much defined as traumatic damage that affects either the skull or the brain, and it is by far the most common cause of death in young adults or individuals aged between 15 to 24 years, and it is much common in males than females. One, because of the behavior of certain males, the drinking, the smoking. PS, by the way, I was not drunk, nor intoxicated with any form of recreational or non-recreational drugs. And road traffic accidents are actually the most common cause of traumatic brain injury, followed by falls as well as assaults. Now, every time anyone has a head injury, you have to make sure that you discover the underlying cause. So you have to pay attention to the speed of the impact, any events that may have led to the injury, things like epilepsy, subarachnoid hemorrhage, alcohol consumption, any events after its occurrence, like for example, did the individual vomit, did they have epilepsy afterwards, were they talking afterwards? Now, before we actually go into depth, I want to give you some basic science so that at the end of this lecture, you have a very good understanding of how brain injury actually affects the components of the head or the components of the cranial cavity. Now, remember that the cranial cavity is predominantly made up of 3 main structures. Within the cranial cavity, the components, you're going to have the brain tissue, you're going to have the blood, and of course, you're going to have the cerebrospinal fluid. Now, the brain tissue is pretty much going to be accounting for most of the volume within the cranial cavity. So it has 80% of the intracranial volume is going to be occupied by the brain. And remember that the brain is partially compartmentalized by reflections of the dura mater, pretty much the falx cerebri as well as the tentorium cerebelli. So remember also that the cranial nerve 3, remember cranial nerve 3 is your oculomotor nerve. So it means that if there's any lesion that's going to be affecting or compressing on this nerve, you may get uneven pupils, which is a symptom or a sign that we call as anisocoria. So you may get this being affected. Just remember that cranial nerve 3 runs, this is supposed to be runs, not runs along the edge of the tentorium cerebelli. And the brain is going to be weighing roughly about 1,400 grams. Then, of course, you have the blood as well, which is pretty much, remember that every organ in the body has to receive a portion of the cardiac output. The brain receives about 15% of the cardiac output, so that's about 75 mils of blood is going to be flowing to the brain. And of course, the brain is responsible for consumption of 20% of the total body oxygen. You also have your cerebrospinal fluid, which is pretty much formed by the choroid plexus at a rate of 500 mils per day, with about 150 mils of the CSF circulating at any given moment. And this CSF has many functions. It controls the temperatures and prevents temperature fluctuations. It also cushions the brain during injury. And remember that this CSF is going to be drained in the arachnoid or by the arachnoid villi. So there's a balance between the production of CSF as well as the drainage of CSF. So keep these principles in mind because it will all make sense when you talk about head injury. Now, there is a doctrine or a hypothesis which is known as the MONRO-KELLIE hypothesis. Now, this is just simply going to be a pressure-volume relationship between the intracranial pressure, the volume of the CSF, the blood, as well as the cerebral perfusion pressure, which I will talk about in the next slide. So the one definition of this MONRO-KELLIE hypothesis goes like this. So the sum of the volume of the brain, the blood, and the CSF within the skull must always be constant, such that if there is an increase in one of the above, if there is a mass in the brain, or if the person is bleeding, or the CSF volume is increasing, then this must be offset by a decrease in the other component. So this will be at the expense of the other component. So how can we put this in words? So when you talk about the MONRO-KELLIE hypothesis, recall that the cranial cavity is a closed cavity. So it states that the cranial components are incompressible. I don't know what's happening to my English. Incompressible, and that the volume inside the cranial cavity is fixed. Okay, such that any increase in one of its components, be it the blood, the CSF, or the brain tissue, is going to be at the expense of the others. Meaning that if there's a mass that's pretty much squashing the brain or increasing the brain volume, then this is going to be affecting the blood supply. It means less blood is going to be flowing to the brain. If the CSF pressure is also increasing, it means that less blood is going to be flowing to the brain matter is going to be squeezed. So it runs the chance of actually herniating into these other spaces that are around it as it's trying to escape the pressure inside the cranial cavity. Now, what exactly is cerebral perfusion pressure? Remember that this is pretty much the net pressure gradient. That's pretty much going to be driving oxygen delivery to the cerebral tissue. It's going to be maintained by a process that's known as autoregulation. Now remember that at any given moment, the cerebral blood flow is approximately about 55 mils per 100 grams per minute of brain tissue. Then of course, this is going to be maintained at a constant rate via what is referred to as cerebral autoregulation, like I already told you. And despite variations in the mean arterial pressure of between 50 to about 150 millimeters of mercury. Now, why is this important? It's because when a person undergoes traumatic brain injury, mechanisms of cerebral autoregulation become disturbed. And this can actually lead to fluctuations in the mean arterial pressure, fluctuations in the cerebral perfusion pressure. Therefore, this leaves the brain being vulnerable to being underperfused. It leaves the brain being vulnerable to hypotension. Now, how do we determine this? So our cerebral perfusion pressure is going to be our mean arterial pressure minus our intracranial pressure. So your mean arterial pressure, you're going to be avoid keeping the diastolic less than 90. So in all head injury patients, at least the diastolic must not go below 90 millimeters of mercury. How do we calculate this mean arterial pressure? There are many different formulae that can be used, but this is the one that I've found to be easy to follow by most students that I've taught. So the first thing that you really need to know is you first have to measure the blood pressure of this individual, and you get your systolic value, you get your diastolic value. You say 2/3 multiplied by your diastolic pressure, then you add that to 1/3 multiplied by your systolic pressure. Remember that the normal mean arterial pressure is somewhere around 70 to about 100. Other literatures give you 65 to about 110, but this is a much easier value to remember. And our intracranial pressure normally should be between 5 to 10. Whenever someone has an intracranial pressure of 20 or more, then you refer to that as increased intracranial pressure, and this should be treated. So if you calculate and you say the MAP minus your intracranial pressure, you find out that the normal cerebral pressure is roughly around 60 to 70. And in a non-operative brain injury, it is fundamental to actually keep the mean arterial pressure or the cerebral perfusion pressure between 50 to 70, so such that you know that the blood is getting adequate amounts of oxygen, getting adequate amounts of nutrients. Because if it's not getting this, then you may be causing what is known as secondary brain injury, which we will talk about in the upcoming slides. Then, of course, the concept of cerebral perfusion pressure could also be used in patients that are hypertensive. That's why we do not lower the BP too fast, because if we lower the BP too fast, this may actually be detrimental to the patient. So let's look at this formula. So our mean arterial pressure is directly proportional to our cerebral perfusion pressure. What do I mean? If I increase the mean arterial pressure, the cerebral perfusion pressure increases. How can we increase the mean arterial pressure? If the blood pressures go up, if diastolic goes up, if systolic pressure goes up, mean arterial pressure goes up. If mean arterial pressure goes up, cerebral perfusion pressure goes up. Then on the other hand, the opposite is true. If you decrease the blood pressure, for example, in someone who's hypotensive, we're going to decrease the MAP. If we decrease the MAP, we're going to decrease the cerebral perfusion pressure, meaning that the brain is not receiving enough oxygen, it's not receiving enough blood supply. Now, also recall that the scalp has layers. Pretty much remember the word scalp as a mnemonic. So you have the skin, the C for connective tissue, dense connective tissue. This is the layer that bleeds the most. The aponeurotic gallia, the loose connective tissue, as well as the periosteum. Now remember that the scalp is highly vascularized, and it may actually be quite a source of major blood loss. And most head injuries are going to be caused by blows to the head from numerous causes. Things like motor vehicle accidents, assaults, even falls from different heights. And remember that the brain is within the skull, and the skull is a closed cavity. It also has these projections or bony prominences which are sharp. It has openings or near openings where the brain can actually be injured. This is very common, especially in deceleration injuries, like for example when the neck flexes or extends or rotates rapidly, for example in an acceleration-deceleration injury. So the skull will be moving, and then it eventually strikes an object, and then it will stop. Now the momentum within the skull keeps the brain continuing moving. So the brain will still be moving within the cranial cavity, such that it now may strike on sharp objects within the cranial cavity, such as the sphenoid wing, such as the frontal as well as the occipital pose, and this can actually cause damage. Also in points where the brain is tethered, such as the foramen magnum as well as the cranial nerves, you may get these as potential sites of injury. And of course, shaking the brain when the skull moves at high speed results in this hemorrhage in the subarachnoid space. You could have this affecting the frontal, the temporal, the occipital lobe. You may get even tearing of nerves and blood vessels, and of course the damage can occur with the head without the head actually being struck, just in an acceleration-deceleration injury in a high-speed car crash. Now remember that head injury is actually one of the most common causes of death and disability. Now, how do we classify head injury? Now, it's classified in 5 predominant ways, and I want you to know these 5 ways. So you have a general classification, you have an etiological classification, or pretty much according to the mode of injury. You have a morphological classification, a pathological classification, and a clinical classification, which I want you to know all 5 of these classifications because they do show up on your exams and because they are quite essential for your clinical experience. Now, beginning with general classification, it may be classified into 2 main groups. You have an open type of head injury or penetrating head injuries. This can either be caused by low velocity or high velocity. Low velocity is going to be things like stabbings. I'll show you a picture of this on the x-ray. And then high velocity injuries are going to be things like gunshot wounds. And then of course, closed injuries is blunt trauma to the head. Then the etiological classification could be divided into missile injuries and non-missile injuries. Missile injuries could be high velocity, like I said, gunshot wounds. These tend to often produce focal as well as diffuse widespread destruction of the tissues. Then of course you have low velocity injuries, things like a catapult, golf ball, skull fractures, even things like epidural hematomas, which can actually injure the middle meningeal artery. Keep this in mind, it's very important. They do ask you this on your MCQ exams. Then of course this is often going to be causing focal injury. Then you also have the non-missile injuries, which can be divided into high velocity injuries as well as low velocity injuries. Now the non-missile injuries, typically the high velocity are things like motor accidents, acceleration deceleration injuries, rotational and even direct impact injuries associated with extensive brain contusion. They may be associated with intracranial hemorrhage such as subdural and intercerebral hemorrhage, and these are actually going to be carrying significant morbidity and mortality. Then of course you may have your low velocity injuries where, for example, you strike the head against an object. You may have what is known as a coup contra coup injury, and you may get these during a fall or assault. And then of course what a coup contra coup injury is, the coup part is where you get the brain. Let me just draw something here on your screen so that you can follow what I'm saying. Let's go to a black screen. This will make my life a whole lot easier rather than drawing on my presentation. So let's say you have the head here, right? Let's say you have the head here. This is the anterior side. This here is the posterior side. Okay, now suppose someone hits into a wall. Let's say this is a wall here. They're moving straight and they hit into a wall. So the brain, or the impact of you hitting this wall, is going to cause some damage here in this area. Now this damage that is caused in this area, this is known as the coup injury. Okay, COUP. So this is known as the coup injury, where the damage is actually happening. Now remember that there is momentum that's going to be causing the brain tissue within the skull and the tissues within the cranium to move. So the brain will also move and strike at the opposite direction here and cause some injury at this opposite direction. So this is referred to as the contra coup injury. Okay, the opposite side, or the contralateral side. So this is known as your contra coup injury. So this is what they are explaining when you talk about the coup contra coup injury. I hope that really makes sense. Let's get back to our presentation. So then remember that your coup injury is the localized injury at the site of the impact, and then the injury at the opposite side is referred to as a contra coup. Of course, consciousness may not be altered in low velocity type of injuries. Then of course in our morphological type of classification, this is pretty much classified according to the type of injury that has occurred. So it may be diffuse intracranial lesions, it may be focal intracranial lesions. So some diffuse intracranial lesions include things like concussions. So a concussion is just simply an individual that has altered mental state that may or may not include loss of consciousness. It may even be momentous type of loss of consciousness, and what is really causing this is that you have an impairment to a part of your brainstem that's known as the reticular activating system. Remember that the reticular activating system is what pretty much is responsible for your attention and your alertness, so keeping you awake. So once that has been disturbed, you can actually lose consciousness. So even when you have a person going to sleep, this reticular activating system actually sends inhibitory signals to the cortex so that you can turn off the cortex and you can actually go to sleep. Then of course this type of injury is referred to as a mild traumatic brain injury. Of course the diagnosis is often clinical and you do not get any CT scans, and the recovery is often complete. However, individuals may come to you with some residual effects like headaches that may last for months after the injury. You may also have diffuse axonal injury, where you have this microscopic tearing or microscopic shearing of the nerve fibers. Even this is scattered microscopic abnormalities. Now, in patients that have diffuse axonal injury, these actually require intubation. They require hyperventilation. You should monitor their cerebral perfusion pressure, and they should be admitted to a neurosurgical intensive care unit. When you do your CT scan, initially you may not see any lesion on the CT scan, and patients are often comatose for a prolonged period of time, and this actually carries a very, very high mortality rate, a mortality rate of roughly about 33%. Then you have the focal intracranial lesions, which are contusion. So you should distinguish between a concussion, which is pretty much your alteration in the level of in the mental state with or without loss of consciousness with your contusion. A contusion is actually a focal trauma that's happening to the parenchymal blood vessels. So this may be leading to petechial hemorrhage and edema. So you can refer to this as hemorrhagic brain contusion with edema. Then of course this may be occurring at the site of injury, a coup injury, or on the contralateral side or contra-coup injury. Then of course it may result in an expanding mass, and of course the insult is going to be affecting the gray matter, but gradually it may actually infiltrate into the white matter. And most of the locations of these injuries are actually going to be in the subfrontal cortex as well as the frontal lobe, and these patients often tend to present with focal neurological deficits, prolonged confusion, or even coma, and they require close observation. They may progress to herniation of the brain, rapid deterioration, and even death. Then of course the other type of focal lesion is of course your intracerebral hemorrhage, or intracranial hemorrhage. These are often caused by traumatic tearing of intracranial blood vessels, and they are very difficult to differentiate from contusions. Now we're going to be looking at intracranial hemorrhage, pretty much our epidurals and subdural hematomas, in another lecture, so I will not focus on that lecture here in head injury because it will make this lecture unnecessarily long. So we also have a pathological classification, which is divided into our primary injury versus our secondary injury. Now, our primary injury, remember that this is the injury that's due to the impact. So this is what you get at the site of damage when the injury is happening. So this is going to be resulting from mechanical forces that are pretty much going to be causing tissue deformation. Now, remember that the injury threshold for different tissues actually differs. For example, survival actually depends on the energy that's reaching the brain. Like, let me give you two scenarios. You have a person that actually hits a brick wall and they're moving at 110 kilometers per hour. This may actually be fatal. They may actually die. Versus a person who's kicked to the head while they're playing rugby. This probably won't kill them. They may lose consciousness and they may have residual headaches, but it won't kill them. Similarly, if you get a shot from a high velocity rifle, this would be very, very, very fatal. Then of course, if you get shot by an air rifle, this may not be probably fatal. Then of course, the mechanism is similar. However, the degree is different. So the severity of the impact is pretty much judged by how severe the initial injury is. Now remember that severe primary damage to the brain is pretty much can lead to coma based on the impact. So the ability of a patient to actually talk, even them just saying a few words after the injury, indicates that whatever else that is happening may not necessarily be due to the primary injury. It may be due to something else. So theoretically, if a person is talking when they're injured, then if they're still alert, then of course this is a very good sign. There's a sign that theoretically they can survive this. But of course there is something that's known as the lucid interval, which I will talk about when we talk about the intracranial hemorrhages in another lecture, but keep that in mind. Then of course the ranges of injuries of primary injury include scalp lacerations, scalp fractures, vascular injuries like epidural, subdural, intracerebral or intraventricular, as well as subarachnoid hemorrhage. You may have injury to the meninges, you may have brainstem contusions, you may have cerebral cortical lacerations, you may have hemispheric contusions, you may also have neuronal and axonal injury without any sign of injury on the head or even site of injury on the face. Then of course when you talk about secondary injury, remember this is someone who's had a primary injury already, and there are other things that can further worsen the primary injury. These things also often tend to be quite preventable, so they happen sometime after the impact has already happened. So it may be things affecting the respiratory system, it may be respiratory complications, it may be perfusion failure, it may be even intracranial hematomas, it may be cerebral swellings, it may be epilepsy, it may be infection, even hydrocephalus. Now, the secondary injuries are often secondary insults which are caused by either poor oxygenation, which is hypoventilation, poor perfusion, which is hypoperfusion, and even hypoglycemia to the traumatized brain. Here are some examples and pretty much how they cause secondary brain injury. We'll begin with hypoxic hypoxia, hypocapnia, and obstruction to breathing. So this is pretty much, you have a reduction in the partial pressure of oxygen in the body. You have a reduction in the perfusion ability of the body. This can be caused by various respiratory problems, like for example, a lack of central drive from the respiratory system, airway obstruction, you may have hemothorax or even a pneumothorax, even aspiration pneumonia. So it means you should rule these things out and ensure that the airway has been cleared in this patient that has a head injury. So this is the most important aspect of care in head injury patients. Then of course, if they have ischemic hypoxia, which is a partial pressure that's less than 8 kilopascals of oxygen and infarction, this may actually lead to cerebral ischemia, and this may worsen the clinical state. So head injury itself is actually a cause of hypotension, and it's rarely a cause of hypotension. So if you get hypotension in a patient that has head injury, then you should investigate this patient further because they could have a splenic rupture. Then of course resuscitation should be done rapidly. Ensure that the patients with head injury accompanied with a systolic blood pressure that's less than 60 for more than a few minutes are actually not going to survive. They rarely survive, so ensure that you address this. So hypoglycemia, because remember that neurons need glucose for functioning. But then again, we have a paradox here. Hypoglycemia can cause secondary injury. At the same time, we should avoid giving dextrose or glucose to patients with head injury because it's neurotoxic. So you should actually strike a balance with this. Then of course, the cerebral edema, there is an increase in the intracranial pressure. Remember, this is greater than 20 millimeters. Now remember that this is, of course, if we're looking at our MONRO-KELLIE hypothesis, if there is an increase in the intracranial pressure, this will be at the extent of the brain tissue. The brain tissue will be squashed, the blood vessels will be squashed, meaning that they're not going to be bringing enough blood supply and they're not going to be bringing enough oxygen, and of course this can lead to further damage. You could have other things like cerebral herniation, you could have infection and pyrexia. Of course, this is the development of meningitis or an abscess after the injury and can reverse a good recovery. And once you do this, you should actually treat this vigorously if there is any infection that is developing. You may have hypotension, hypothermia, hyperthermia, metabolic disturbances. So you should address all these things when you're managing your patient. And then you could also have a hematoma. Remember that once more than 150 mils of blood accumulates, the brain will not be able to compensate for this. So if you have your intracerebral, your subdural, your epidural hematoma, then of course this can lead to deterioration following a head injury. Then, of course, seizures are also very common in head injuries. Remember that when you get a seizure, the brain is not getting enough oxygen, so these should be stopped rapidly with diazepam in small doses, and you should also add on some other drugs like phenytoin and even valproate to actually prevent any recurrences that may be there. Now, what about the severity of brain injury? Now, how do we classify this? There is a special scale that is used. So this is the most commonly used assessment for management of these patients, and it can be easily done by most healthcare workers, and it can be easily interpreted. Very, very easy to do. It's known as the GLASGOW COMA scale. So now this GLASGOW COMA scale is pretty much going to be having three parameters: eye opening, the best verbal response, and the best motor response. So you can just remember EVM in the order of eye is scored out of 4, so 4, 5, 6. Verbal is scored out of 5, motor is scored out of 6. So EVM, eye, verbal, and motor. So with the eye, if the patient is opening their eye spontaneously, you give them a score of 4. So we can grade my GCS at the time of my accident right now. So if the patient is opening their eye spontaneously, give them a score of 4. If they're opening to verbal stimulus, give them a score of 3. If they are opening in response to pain, give them a score of 2. If there's no response, give them a score of 1. So I was able to open my eyes spontaneously after I, of course, regained consciousness, so we can give me a score of 4 at this. Then verbal response out of 5 here. Oriented and converses, so this is oriented to time, place, and person. So if they know who they are, they know where they are, they know what time of date is or what time of day it is, you give them a score of 5. If they're disoriented but converses or communicates coherently, give them a score of 4. If they're inappropriate response and intelligible single words, give them a score of 3. If there's inappropriate sounds like moans and groans, give them a score of 2. If there's nothing at all, give them a score of 1. So at that time I was quite confused or disoriented, so we can give me a score of 4. So I got a 4 out of eyes, I got a 4 out of the verbal here. So we are at 8 so far. Then of course our motor response here, if they obey your commands, you give them a score of 6. Ask them to lift their head or lift their hand, ask them to do simple commands that they can follow. Then of course, if they're not able to do this, then they localize to pain. For example, if you rub over the sternum or you rub over the eyebrow, or you pretty much pinch the earlobe, then they're able to bring their hands above the clavicle to the stimulus or to the head. If they withdraw from pain where they bend their arms at the elbow but features not predominantly abnormal, then you give them a score of 4. If they are in a characteristic position, which is known as abnormal flexion or decorticate position, where you get flexion of the upper limbs and extension of the lower limbs. You can think of the mummy position, how mummies are kept in tombs. If you have no idea what mummies are, just search for mummies in tomb or mummy position. They'll give you how it looks like. And that's the characteristic position that the patient may be in. You refer to this as a decorticate positioning. Then, of course, it may be decerebrate type of posturing or extension of the arms as well as the lower limbs. This usually indicates a midbrain injury. You give them a score of 2. Then, of course, if there's no response at all, there's nothing, you give them a score of 1. So I was able to actually obey commands, so we give me a score of 6. So 6 plus, we gave me a 4 here, so that's 10 plus another 4 here, so I had a 14 out of 15. So the maximum score you can get is a 15 out of 15. The lowest score you can get is 3 out of 15, so you can never get a 0. Never should you ever record GCS 0 out of 15. If you ever do that, quit doing medicine. Just stop. Anyways, so this is how you grade the severity. So someone with a GCS of 15 with no loss of consciousness indicates a minor head injury. Someone with GCS 13 to 15 indicates mild head injury. Someone with 14 or 15 with loss of consciousness indicates a mild head injury. So this is where I was with a mild head injury, because I had a GCS of 14 and I had features of loss of consciousness because I was unconscious for about 20 to 30 minutes. Then, of course, if someone has a GCS between 9 to 13, this is moderate head injury. 3 to 8 is severe head injury. Now, anyone that's less than 8 is pretty much unconscious. They are comatose. Okay, anyone who has a GCS less than 8, they are comatose. GCS of 3, they are pretty much dead. So what's actually the value of this GCS in head injury patients? So the first and foremost thing that you really need to understand is that it helps in determining the need for admission. So your admission criteria. You want to admit patients that have mild traumatic injury with loss of consciousness, moderate, severe, you admit these patients. Of course, it helps with triage, especially in mass casualties. For example, someone who has a GCS of 3, the prospect of them surviving is not so good, versus someone who has a GCS of maybe 9. So you would put all your resources, if they are limited resources, towards the patient with the GCS of 9. But of course, if you are not resource limited, then of course, even the patient with the GCS of 3 should be attended to first, because they seem to be in a much worse state than this patient. Then, of course, it also helps determine the line or the course of management to undertake. If this management must be quite extensive, for example, someone with a GCS of 15 wouldn't require that rigorous type of monitoring, that rigorous type of management as compared with someone with a GCS of 8. Then, of course, it may also help in assessing the effectiveness of your treatment, so whether this person is improving or deteriorating. So if they are improving, our GCS should improve. Then, of course, it helps determine the frequency of the monitoring of the patient. Someone, again, with a GCS that's lower requires more frequent monitoring versus someone with a GCS that's higher. But even this one with a GCS that's higher, there is what is known as a lucid interval, where they can actually slip and deteriorate very quickly, so they also should be monitored. It also helps estimate the prognosis of the patient, especially if you did it early on the onset of the presentation. You can see that, okay, if their GCS is improving or if their GCS is static, then we can actually have an idea of whether this person has a prospect of surviving and doing quite all right. So this is why the GCS is actually very important in head injury patients. Now, how do we perform our clinical assessment? So we want to do a primary survey, your ABCs, with, of course, cervical collar, until the fracture is actually been ruled out with imaging. Then also do your secondary survey, where you take your full history, if possible, also get your collateral history, perform a complete examination, and also order for some investigations. What are the important questions that you're going to be asking you on your history? What is the mechanism of the injury? Was this direct trauma to the head or a deceleration injury? What was the time of the injury? Did they lose any level of consciousness at the scene or when they're being transferred to the hospital? Was there any history of loss of consciousness, and did the patient regain it? Remember your lucid interval that I told you about? Was there any amnesia in this patient? Did they have any convulsions? Did they have any bleeding from the ears, the nose, or anywhere else? This may be pointing you towards hypoxia or hypotension. Or did they have any discharge? Are they having any headache, nausea, vomiting, or even a falling pulse rate, or even a rise in blood pressure? All these things are indicating of cerebral edema. Then of course you ask them for their last meal because they may require to go to surgery. You ask for any comorbidities, you ask for any drugs, especially aspirin and other anticoagulants, even insulin. Then of course ask for any illicit drugs or alcohol that has been taken in this patient. Then, when you examine this patient, perform a complete neurological examination. So do your GCS, do your pupillary light reflexes and responses. The pupils can sometimes be unequal. You refer to that as anisocoria. Then, of course, you may have abnormal light reflex that may indicate intracranial hemorrhage. You check for the tone, the power, the reflexes, the sensation, and the coordination of the upper limbs, the lower limbs, as well as the cranial nerves. Then, of course, examine all the other systems fully, the cardiovascular, the respiratory, the GIT, the GUT, and, of course, the musculoskeletal system. Also, do not forget to check for your vitals. Very, very important, especially in head injury patients. So check for your pulse, your temperature, your blood pressure, and your respiratory rate. Now, when it comes to investigations that we can order in head injury patients, we want to start with diagnostic imaging. So we can start off with a CT scan. So because a CT scan, an emergency CT scan, is much easier to use and diagnose to rule out any bleeding inside the cranial cavity, and it's much cheaper than an MRI. Go for an urgent non-contrast CT scan. So this may show you any contusions, any hematoma, any midline shift, any fractures, any ventricular or even brainstem injuries, any hydrocephalus, or even cerebral edema. Then if you do have resources to do an MRI, you may do an MRI later on. You may also order for x-rays of the skull to check out any skull fractures, the relative position of the calcified pineal gland, or even presence of intracranial air. You may do a skull x-ray, AP, lateral, Townsview, which is pretty much important for cervical fractures or displacements. You may also order for some serial x-rays, pretty much your trauma series, where they order for your skull x-ray, your neck x-ray, your abdominal, your chest x-ray, and of course x-ray of the limbs and the pelvis. Then you may also order for a carotid angiography. These are some of the diagnostic investigations that we order for. So here's a picture of a CT scan. So this is a patient that had a high velocity injury. So this person was actually shot, and as we can see, the bullet here entered into the anterior aspect. So how do I know that this is a CT scan? I'll do a separate lecture on how to read CT scans and all that, but for now just know that this white area here, of course, is your bone. So this whitish area here, this is the bone. Of course, air is going to be appearing dark on the CT scan. So everything that you see is air. The brain tissue is going to be appearing grayish in color. So as we can see here, there is a discontinuity here of the bone. So there was actually a fracture that's happening, that's affecting the frontal bone here. And it's you can see that there are some artifacts that you can see, especially lost here just in front of the brain stem over there, just in front of the prepontine cystine, or cystine rather. You may see these artifacts. These are pretty much pellets of the shotgun. So this person was shot, and this is what the CT scan looks like. Then of course, as you can already tell, I don't know what circumstances this actually happened in, but this person was stabbed. This person also was stabbed. So this is pretty much what the x-rays look like. Now, supportive investigations include things like a full blood count, a cross-match, group and save, abdominal ultrasound if there are any abdominal injuries, urea electrolytes, creatinine, liver function test, the blood glucose, and of course your arterial blood gases, for all important reasons. Your full blood count, if this person is anemic, you want to address that. You want to transfuse blood. So that's why you want to cross-match and group and save this patient. For the abdominal ultrasound, you do what is known as a fast scan, a focused abdominal sonography for trauma patients, or for trauma, where it's going to be looking at the 4 windows in the abdomen and see actually where or if there is actually any injury. And of course, urea electrolytes, creatinine, functioning of the kidneys, liver function test to function of the liver, blood glucose to rule out any hypoglycemia or to treat any hypoglycemia that may be there, and arterial blood gases to look at whether this person is in acidosis or alkalosis, as well as to monitor the partial pressure of the respiratory gases. And of course, what are the indications of admitting patients to the general hospital? So if a patient is oriented and if they've had any skull fractures or any suture diastasis, if there's any persistent neurological symptoms or signs, if there's any confusion or any depressed level of consciousness at the time of examination, if there's any difficulty in assessing the patient, for example, if they are drunk or they are very young or they have epilepsy or they attempted suicide, if there's inadequate social conditions or lack of responsible adult or relative to take care of this patient, if there's any coexisting medical conditions like a coagulating disorder, and all patients with impaired consciousness. That's why I was admitted to the hospital, because I had lost consciousness. These are the indications for the patients that should be admitted. Then indication for those that require skull radiography after a recent head injury. So pretty much all oriented patients that have a history of loss of consciousness or amnesia, of which I had, and that's why I did get a skull x-ray and I did get a CT scan. If there's any suspected penetrating injury, if the CSF or even blood is being lost from the nose or ear. And here's actually a nice trick to tell whether the bleeding is CSF or whether it's blood. You simply get the sample of this and put it on a filter paper. So if it forms a halo around that on the filter paper, then it's most likely CSF. If there's no halo, then it's blood. Then, of course, if there's an scalp laceration to the bone greater than 5 centimeters, if there's any bruising or swelling, if there's any violent mechanism of injury, persistent headache or vomiting, and of course, if the fall is from a significant height in the child, depending in parts of the age of the child, and on the hard surface, if there's any tense fontanelle or even suspected non-accidental injury. And all patients with impaired consciousness or neurological signs, unless an urgent CT is performed. And of course, here are the indications for performing an urgent CT, plus or minus getting a neurological consult. So if there's any coma, confusion, neurological signs persisting after resuscitation, if there's a deteriorating consciousness or progressive neurological signs, do a CT scan. If the skull X-ray actually shows a fractured skull, together with maybe confusion, or with or without impairment of consciousness, if there's any epileptic seizures, if there's any neurological symptoms or signs, if there's any open injury, get a CT scan. So if there's a depressed compound, a fracture of the skull vault, if there is a fracture of the base of the skull, or even a penetrating injury. So if you get bleeding from the nose, if you get bleeding from the ears, it means that the skull has fractured somewhere. There is a basal fracture. Then of course, or leakage of CSF rather, not just bleeding, leakage of CSF. Then of course, you have there's an unstable systemic state precluding transfer to the neurosurgery, then get a CT scan. Of course, if the diagnosis is uncertain, and in a child, if there is a tense fontanelle or suture diastasis, then get a CT scan. Then, of course, what's your indication for you getting a consult to your neurosurgery team? If you get an abnormal CT scan, consult neurosurgery. If there's a high or even a mixed density intracranial lesion, get a CT scan. If there's midline shift, obliteration of the third ventricles, relative dilatation of the lateral ventricles, obliteration of the basal cystine, if there's any intracranial air, if there's any subarachnoid or intraventricular hemorrhage, you should order for or actually get a neurological consult after you do your CT scan. Now, how do we manage these patients? Now, first and foremost thing, remember you're doing your primary survey with cervical collar securing. So with our airway and breathing, you make sure that the head of the patient is at least 30 degrees in the neutral position. Put a collar around their neck. Protect the airway, so you can use a mouth gag, you can use an endotracheal intubation or even a tracheostomy wherever it's required. This is very important, especially in patients that are unconscious. Then, of course, suction the throat, suction any secretions that are out. If there are any dentures, remove the dentures. Then, of course, give them nasal oxygen or ventilator support. At least ensure that their oxygen saturation are above 90%. Then for your circulation, gain your venous access with your 2 large bore cannulae. Start running your fluids, your crystalloid. Of course, monitor your blood pressure. The BP, the systolic BP should be greater than 90. Do not give dextrose. So you should, your mean arterial pressure should not go below 70. So your aim is to keep it at 80 millimeters of mercury. And then IV fluids can be initially given, and then NG tubes can be given later if they can't feed. Make sure you monitor your electrolytes and you have electrolyte balance. If they're bleeding from anywhere, compress it, suture it up, arrest the bleeding. If you resuscitate a patient with trauma and they are not responding and they're still hypotensive, then you should look for another cause. Start to look for the spleen, start to look for any fractures of the pelvis, because they could be bleeding from the inside. Then, of course, your disability and exposure, disability drugs and exposure. You do your GCS, Glasgow Coma chart. Then you do not sedate any patient with head injury. So avoid analgesics which are sedative, things like morphine, pethidine. Those are going to be reducing the levels of consciousness even further. So give your non-sedating analgesias, give your antacids to prevent any Cushing's ulcer. There is some debate about the use of corticosteroids such as dexamethasone and betamethasone, but in my experience where I train from, we rarely use these in patients with head injury. Then of course you prevent any hyper or hypothermia. And then if they have a scalp laceration, make sure that you shave the hair at least 2 centimeters around the wound. Remove any foreign body, so you debride as much as possible, debride the skin as much as possible, and suture the skin in single layers, leaving a stitch in for at least 7 days. I remember when I was in my surgical rotation where we had a patient that whose head was injured, and a brick fell on their head, in short, and they had this huge laceration, and we had to actually suture it up in the emergency department. It was quite an experience, not for the patient though, but for me it was quite an experience, being actually there in the moment and actually working on that patient. Then of course use lidocaine with adrenaline to reduce bleeding. Remember, like we said, that the scalp tends to bleed a lot, so order blood for this patient because they can actually bleed out and die right in front of your eyes. And of course antibiotics must be given to patients with fractures, so traditionally this is to prevent any further infection. Of course, if they have persistent rhinorrhea or torrhea, this requires surgical treatment to repair the scalp defect. Cover them on antibiotics like penicillins and ampicillins that can be given. Then of course patients that are susceptible to seizures should start on prophylactic medication like carbamazepine, phenytoin or phenobarb. Then of course if the patient starts to seize, treat the seizures like you normally treat other seizures. Remember that with glucose and fluids, give your fluids. If they are hypoglycemic, give your bolus of 50% dextrose, but avoid giving intravenous glucose because it tends to be nephrotoxic. Then of course bladder and bowel care, good nursing care, so you should perform some hourly turning for this patient to prevent decubitus ulcers, and feeding should be within the first 24 hours so that you can assess if they can swallow and assess if an NG tube is actually needed. So you should actually aim to getting them at normal diet by day 7. So there are some patients that may benefit from craniotomy, that's surgery. Those patients that have an acute extradural and epidural hematoma, those patients with acute subdural hematoma, even patients with a depressed skull fracture. So remember that you may perform a craniotomy, which can be done, and a cranial flap can actually be used. And then of course the clot is evacuated, followed by applying the hitch stitches between the dura layers and the scalp, and then of course covering them on post-op antibiotics, analgesia, and some anticonvulsants should also be given. Now, in some patients with head injury, you may get an increase in intracranial pressure. So you may get features of bradycardia, you may get hypertension with a widening pulse pressure, you may get depressed respirations or apnea. So bradycardia, hypertension, and irregular respiration, you refer to that as Cushing's triad. This is pointing you towards an increase in intracranial pressure. Now, how do we manage this increase in intracranial pressure? We elevate the head end of the bed. We can give diuretics, mannitol 20% at 0.5 to 1 gram per kg, slow infusion in 30 minutes, 200 mils IV 3 times a day, or you can give furosemide 40 milligrams IV 3 times a day. It should not be given in cases of intracranial hemorrhage. Then of course you may also give hypertonic saline, 3% saline. You may also hyperventilate. Now, why are we doing this? If we hyperventilate the patient, we're decreasing the carbon dioxide partial pressure and we're increasing the oxygenation. So these effects have a vasoconstrictory effect on the brain, so it means less blood is flowing to the brain, less edema is going to be done. So you only do this in 30 minutes when the other measures have failed. Then of course you may perform decompressive craniotomy, where you do a ventriculostomy with burr holes. Now here's a mnemonic for remembering the measures to lower intracranial pressure. You can remember HIVED, so H for hyperventilation, I for intubation with pre-treatment and sedation, V for ventriculostomy with burr holes. Then of course you can elevate the head end of the bed, and of course diuretics plus mannitol. What are some of the complications of head injury? They may be divided into early and late. Early complications include brainstem injury, which can be due to coning, a compression over the cerebellum and the medulla. You may have CSF rhinorrhea, which is indicating a tear in the dura mater following injury to sinuses, like for example the frontal, the ethmoid, and the sphenoid. These have a risk of developing into meningitis. Then of course treatment is conservative. You give them a 10-day course of IV antibiotics and observe the patient. Surgeries can be done to reduce the fracture of the mid-third of the face, and then you can also explore the anterior cranial fossa. Then It may also result in CSF autoria, meningitis, pituitary damage, endocrine failure. This often require high doses of hydrocortisone, 200 milligrams 4 times a day, and aerosol, as well as depressed fractures. And these are often causes some injuries to the dura venous sinuses, and it may lead to torrential hemorrhages that may actually be quite life-threatening. So a depressed skull fracture should never be elevated unless if it's done by a professional or someone who is experienced in the field. Then, of course, late complications include chronic subdural hematomas. You may have early post-traumatic epilepsy if someone needs anticonvulsants for 3 years, or you may have late post-traumatic epilepsy, which is often due to scarring and gliosis of the cerebrum. You may have post-traumatic amnesia, post-traumatic hydrocephalus, as well as a post-traumatic headache. So back to a warm-up question, where you have a 35-year-old patient that is seen in the casualty following a road traffic accident. The patient smells of alcohol and has a laceration on the occipital area, and answer the following questions. So what 2 things would you ask on your history? You ask for a history of loss of consciousness. You ask a history of amnesia, which may be pre or post-traumatic. Then, of course, explain how you would examine the occipital laceration. So you wear a glove, and with a gloved finger, you should palpate for any fractures in the bone through the laceration. Then, of course, how would you assess the level of consciousness in the patient? So your Glasgow COMA chart or Glasgow COMA scale, eye-opening, verbal response, and motor response. 4 localizing signs would be, for example, decide on where the laceration is, whether it's on the right or the left. The pupillary size, are they the same size or are they asymmetrical? Any presence of any cranial nerve palsies, and is it asymmetrical? Then if there's any hemiplegia or hemiparesis. Then, of course, list 4 reasons you might ask for a CT scan in this patient. So this patient may have a Glasgow COMA scale that's less than 7, get a CT scan. If they have a history of a lucid interval, get a CT scan. The high history of alcohol intake in this patient requires them to get a CT scan. Then, of course, it's very difficult for them to examine the patient, so get a CT scan, especially the patients that are drunk. Then, of course, if there's any localizing sign in this patient, you should get a CT scan. So I really hope you enjoyed that video on head injury, and I hope you learned something, and I hope you will save a patient's life that comes in with head injury due to a road traffic accident. If you did, drop a comment and share your experience. Also, do not forget to answer our question for thought that we had in the first few slides. If you really enjoyed, hit the subscribe button, hit the bell notification icon to also be receiving notifications of such videos every time I post. Until next time, my name is Dr. Moses.